folk online. Just straight ahead. Yep, great.
I'll make a start. Good morning, everyone. Brian Power, lead the Mood Disorders Unit here at Hollywood, and welcome to another one of our grand rounds. We have Dr. Nathan Gibson presenting in our lecture theatre at Hollywood. And yes, and we have an online audience from locally, but from around Australia as well. And first, I'd like to acknowledge the Whadjuk people of the Noongar Nation as traditional custodians on the land on which Hollywood Hospital stands, and pay our respects to the elders past, present and emerging. We're very fortunate in Australia to be able to offer ECT the way we do. It's not the same in every other country around the world. And one of the key reasons for that is the tireless work that goes on in various jurisdictions by the Office of the Chief Psychiatrist. And today we have Dr. Nathan Gibson presenting from the Office of the Chief Psychiatrist, and he's going to talk around, I guess, some of the reasons they play quite a pivotal role in working with our ECT practitioners to ensure really good outcomes for our ECT patients. So I'm going to hand over to Dr. Nathan Gibson.
Thank you very much, Brian. I'm very pleased to have the opportunity, and my thanks to Hollywood and to Brian for inviting me to speak today. Sorry, let's get this going. What was that not moving? It was before. That's all right. Okay, so I acknowledge we're on Whadjuk, Noongar, Whadjuk as well, and pay my respects to elders past and present. My thanks to Dr. Emma Crampon, Mr. Vaughan Lochner, Ms. Grace Lee, and Ms. Sarah Holland, who put a lot of this data together for me. So that's our menu today for breakfast. For the people on the eastern states, it's probably a midnight snack, I guess, knowing the time difference. But we'll talk a little bit about what my office does, a bit about the legislation, which I think is very important for people to know, a bit about standards, which you will know already about, a bit of the data on ECT, which is not often in the public domain. It is there, but it often doesn't get discussed, and some key safety learning. So I hope that will be useful for you today. So who is the Chief Psychiatrist? I am created by the Mental Health Act. It defines my statutory functions. Interestingly, in Western Australia, the Chief Psychiatrist is entirely independent of the Department of Health and the Mental Health Commission. We're the only state where the Chief Psychiatrist is a separate statutory entity. So I'm not part of Department of Health or the Mental Health Commission. I'm not the Chief of Psychiatrists, and I don't run services. My role is around clinical leadership. In the way that things are structured in WA, there are very few senior psychiatrists in the higher levels of executive services. So I have a leadership role. I am a regulator. We have a strong knowledge about the Mental Health Act clinical interface, and we work through a safety and quality lens. So what do we do exactly? Folks report stuff to us about ECT, about things that go wrong, and there's some nods in the room. We know about that. We go and review services. I have a role to authorise hospitals for involuntary patients and approve a number of things, including ECT suites and our authorised mental health practitioners as well. We also, and I think it's very important, we also have a clinical help desk, which is open. It's only open Monday to Friday, but for any clinician in WA who has a concern that they can't resolve at a local level that might involve the Mental Health Act or a really tricky clinical, ethical, legal Mental Health Act issue, we're very happy to take that call, and I'll leave that number at the end. I'm sorry for the people in the eastern states. You'll have to go to your local folk. I can't help you with that. All right, so what is the background? What is the law around ECT? These are the bits of the Mental Health Act, and I'll take us through those shortly. What I wanted to say here is that I don't credential practitioners around ECT. I credential services, but not practitioners. The credentialing happens at a local level. So this is the legal framework. ECT is actually highly regulated. In some jurisdictions around the world, it's not. In some jurisdictions around the world, it's banned. But in WA, it's highly regulated. So a person must not perform ECT unless they comply with the Act, with the sections of the Act. And in fact, there are punishments, potential punishments, offences under the Act, $15,000 fine or imprisonment for 2 years if someone doesn't comply with that. The reality is no one has ever been charged or found or punished under the Mental Health Act around ECT, and we'll talk about that as well. But it flags the, if you like, the community concern around ECT. Now, I know and we know that ECT is an evidence-based, established, effective treatment with known side effects, and I think it's still in the public mind. It's still variable in how people perceive this. There's still a degree of controversy, so that reflects these offence punishments reflect that. Okay, apologies, it's a little bit small, but some of the things that the Act says, which seem simple, but I'll go through them. ECT for an adult voluntary patient, as in the folk that you'd be seeing here in Hollywood, with capacity requires informed consent. Sounds simple, but it's in the Act. ECT for an adult voluntary patient who lacks capacity requires informed consent from an enduring guardian, a person responsible as defined under the Guardianship and Administration Act, or via an advanced health directive. ECT for an involuntary adult patient, or MIA, and MIA talks about mentally impaired accused individuals, so folk in the prison system essentially. ECT for an adult involuntary patient, or MIA, requires approval by the Mental Health Tribunal. So we have a tribunal that must approve all involuntary ECT. Emergency ECT can only be performed for an adult involuntary patient or mentally impaired accused person detained at an authorised hospital. So Hollywood is not an authorised hospital. If it's required to save their life or prevent imminent risk of serious physical injury, and if I approve it. So emergency ECT can occur and does occur, but you have all those criteria. So ECT in WA, and you may know this, is prohibited for kids under the age of 14. Kids between 14 and 18 who are voluntary require informed consent as usual, but all kids ECT must go through the Mental Health Tribunal first in WA. Again, different in different states, but that's how we are here in WA. ECT for a child over 14 who's involuntary, and there's a small number of kids who are involuntary who might have ECT, very tiny number, they also require approval by the tribunal. So essentially, the messages are nothing under 14, otherwise tribunal for kids. And this is the approval of ECT services. So we've got 13 ECT services in WA, 2 in country WA, one's not up and operating yet, but it's approved. There's one in Albany, and Geraldton will, when that opens, will have an ECT service. But lots of ECT services in metro area, public, private, and also public-private partnership as well. But before they can do that, we have to go and approve the service, and we'll talk about the standards and guidelines, but they have to be gazetted in the public, in the government gazette. So these are all the kind of processes. So what are standards and guidelines under our Act? So standards under the Mental Health Act mean clinicians must comply with those. Guidelines by the chief psychiatrist or noted by the chief psychiatrist must be considered. You must have regard to them. So you don't absolutely have to comply with guidelines. So we'll talk about our ECT standards and guidelines. The ECT standards you've got to comply with. The ECT guidelines you can consider, but you don't necessarily have to comply with. So this is the standard. We've just published the new standard, and it's got 4 components. A component on ECT service delivery, a component on the consent and legal framework, a component on the provision of treatment, and safety and quality reporting. And that's available on my website. And the guideline, which was published at the end of last year after a very, very long gestation, and my thanks to many colleagues, some of whom are in this room, who were involved in feeding into that process. The length of gestation, I guess, reflected the complexity in some ways. But the Mental Health Act says that medical practitioners performing ECT must have regard to the guideline, and the Mental Health Tribunal must have regard to the guideline. Again, that's available on the WA Chief Psychiatrist's website. I'm absolutely aware there are other guidelines in other states as well. Not every state has specific standards around ECT, and not every state has the same legislative requirements for ECT. So let's talk a little bit about the data. What folk have to report. So what's required by law to report by the service is how many ECT you do, the mental health status of the patient, and any serious adverse events. That's required by law to report monthly by services. Apologies, it's a little bit small, but I'll just make a couple of notes. These are a breakdown of the voluntary and involuntary courses. The green there is voluntary. You can see that the vast majority of courses in WA are entirely voluntary. There's a few mixed courses, so they're the dark shading, where someone might be voluntary and then become involuntary, or involuntary and then become voluntary. And there's a small-ish number of involuntary courses each year. And I just take you to the total numbers here. These are number of treatments, and these are number of courses. So we do quite a lot. So 607 courses a year, and over 6,000 actual treatments. The numbers had been going up for a decade or more. Around COVID, and well, it's actually slightly post-COVID, but we've started to see a decrease in the number of courses and a decrease in the number of overall treatments, probably reflecting the decrease in the courses. And I still don't know exactly why that is, and I would be very interested for any comments on that. So we're seeing a slight decrease. I don't necessarily think it's not an evidence-based issue that I'm aware of. It's not the evidence saying ECT is not helpful. It's not necessarily a population or if you like, a civic uprising against ECT. We don't quite know, but I'd be interested to hear the thoughts on that. Oops, sorry. And this is the private-public percentages. As you can see, mostly pretty consistent, the amount of private and the amount of public that's done. I just had to get a bit of alliteration in there for anyone who noted that. So we saw the total number of ECT treatments decreasing. Maintenance treatments are increasing, and that may reflect a relative issue rather than an absolute issue, so that maintenance is still continuing at the same rates while acute treatments are, we're seeing a slight decrease in others, but generally the acute treatments are mostly reasonably steady. They're going down a little bit, as you can see there, and that might be the key contributor. The emergency ECT, you won't see it because it's absolutely tiny at the top there, and where we've got the numbers. They're the numbers there of emergency ECT in WA each year. So not very much. So around 20-ish, 20 to 25 generally per Yeah, and these are life. This is the life-saving ECT when someone's involuntary and they can't get to the tribunal in time, so therefore they can seek some initial emergency ECT before they get to the tribunal. That's not to say many other ECT is not life-saving as well. So there's a thing called serious adverse events listed in the Mental Health Act, and they are premature consciousness during a treatment, anaesthetic complications during ECT recovery, e.g. cardiac arrhythmia, acute and persistent confused state during ECT recovery, muscle tears or vertebral column damage, severe and persistent headaches, and persistent memory deficit. So these were determined 10 years ago when the Act was developed. And again, this was if you like, a strong consumer push to have a tracking of the side effects of ECT. Interestingly, there was no consumer push to have a tracking of the benefits of ECT, but that's as it is. So again, my apologies, very small table, but I'll take you through the key points. So these are the adverse effects. You can see over a course of a year, let's say it's 130 to 150 what they call serious adverse events. So these are not just a small headache that lasts an hour. Headache has to last 4 hours or more. And these are the percentage of courses that have an adverse event. Now, the adverse events are reported for a course. So someone might have several adverse events during a course and it would be reported once. That's just how it's reported. But so it's about, let's say it's about 10 to 12%. So 1 in 8, 1 in 9 courses has a serious adverse event. Now, that's not to say that the person hasn't been consented for that and they are aware that could occur. It's also, I think, not to say that it's a reason to stop ECT either. So these may not be a reason to stop ECTs. Occasionally it might, of course, absolutely, but it may not be. So you'll see the majority are the headaches and the memory deficit. And you can see over the last 5 years, no muscle tears, vertebral column damage, and that will become relevant as we talk a little bit more later. The premature consciousness one is interesting. Now, the issue here is that we're not required to get details of these from services, so we actually don't know what's occurred. We only know that they've ticked the box to say that has actually occurred. So this is obviously an anaesthetic issue, and when we put less than 5, it means we do that for patient confidentiality reasons, although in this day and age that may be less relevant, but of metadata and various things. But it is interesting to see that figure. It would be interesting to have more information about what that actually meant, I think. Yeah, so we can talk about that in a minute, and certainly ask questions at the end. So headaches and memory deficit are most common. We mentioned no muscle tears, and yes, we've said that already. So this is just the same in a graph. Probably this is really the only interesting one, which is the persistent memory deficits, which have gone up. And I wondered whether is that an increased reporting effect, or is it a true effect? We actually don't know. I would think it's an increased reporting effect as people become increasingly comfortable with reporting these. So the Act has been around 10 years, but it often takes a while for people to get comfortable reporting. So what about notifiable incidents? These are the other things that get reported to us. And these are things, and this is under the Act, these are things like death, very serious prescribing errors, very serious other incidents. WA Health has a thing called Datix Sims, a platform that it uses, and different organisations use their own platforms to report to us. So these are the ones. Now, I've said punishable offence under the Mental Health Act. That should read potentially punishable effect, because no one's ever been punished. And I'll talk a little bit about that. I don't want people to get scared, but it is important to note with these, there is the potential for an action through the Mental Health Act. Who takes that action? I don't take that action. It's someone would have to report that to the police. The police would then have to lay a charge. The process would have to go through a court process, and there would have to be an outcome from that court process. So that's how that works. I'm not the policeman of the Mental Health Act in that regard. Certainly, anyone can approach the police. The interesting thing, of course, is that because this has never happened, you would find the police force are probably uncertain how to approach these things realistically, and it would be very it would be a precedent, really. So these are the things. So the Mental Health Act status not checked prior to each ECT treatment. Again, maybe not relevant directly, mostly in private settings, but in private public settings, which I'm aware Ramsay are involved in different places. So someone going from voluntary to involuntary, and it hasn't been, they might have consented to the voluntary, but then they've become involuntary, and ECT has proceeded without getting approval from the tribunal. So you'll see a theme as arising here. Patient consent not obtained. This is generally about people being involuntary who shift over to become voluntary, but then actual consent for ECT is not obtained. So it's generally the transition issue. ECT administered after the Mental Health Tribunal approval has expired. The tribunal approval has a time and number of ECT treatments, and if you give ECT after that time, the tribunal approval is not valid. So it's like doing it without approval. And if the tribunal says you can do 12 and you do 13, again, you're going outside of the validity of the approval. And again, the tribunal will be for kids and for involuntary adults. So what happens when one of these things occurs? And they do occur from time to time. And we get you can imagine, we get very distressed clinicians ringing up and saying, this is not what we'd planned, this was a mistake in the process, are they going to chuck me in jail? And the answer is no, but there's a certain process that's really helpful to work through. And this is a general process in some ways, but I'll put it here because I think it's an important process to think about. So it's always about the patient and the family. Open disclosure, which means letting people know it's happened. Don't try and hide it. It would be a problem later. And letting people know what their rights are in that process. You might think, well, that opens us up. But in fact, it tends not to. People then feel, in most cases, it's been a sense of trust in the relationship between the person and the clinician, and the person's gone, I understand it was a mistake, that's okay, and that's fine. Obviously, it has to be reported to me, and we'd encourage folk to report that to the tribunal, because you may need to go and then approach the tribunal to have for example, if someone's gone from voluntary to involuntary, you have to approach the tribunal anyway, but you may need to go through the tribunal process. That's not a process to judge the mistake, it's a process to clarify whether someone can have further ECT or not. These must have a learning process, and that's the focus we have. So we strongly encourage, and this happens, we strongly encourage the service to review this and look at changes in process to prevent this happening again. Standard stuff, standard safety and quality stuff. And other governance issues, do speak to your lawyers and your medical defence organisation. In most cases, as I said, or in all cases that we've had, there has been no issue in that the individual has not sought legal redress, but they've, that engaged with the person has usually managed that process, and the ECT usually continues. That's our experience. And so this office, the chief psychiatrist, isn't about saying, you've been terrible, I'm calling the police. It's about saying, make sure the patient is aware of their rights. You might need to involve the advocate, etc. So that's a helpful process, and a process which is good for the patient, good for their family, good for clinicians, and will generally lead to better outcomes than a secretive approach, which can be problematic. So the other notifiable incidences, which are not likely to have a risk of a punishment, medication errors. These are the ones we receive. So these are the common-ish ones. Medication error, pre-CT treatment, the pre-CT nursing checklist not completed, and that has significant relevance for some of the key learnings that we'll talk about shortly. So again, it's the classic surgical checklist and checklist process. It's not just a tick box, it's critically important for safety and quality. And no identification band on the patient for ECT. ECT is a procedure, and it's really important. You don't want to give ECT to the wrong person. I can assure you that's not a great thing. Notwithstanding that, it may not have many problems for that person, but, I think it's important to note that identification is a core quality and safety issue. Okay, so how do we feed back to the services to give them some information about this quite rich data we have on safety and quality, really? We do an annual report. We table it before Parliament each year. All of our ECT data and analysis is in there. The question is, of course, does anybody read that? Now, we know the mental health minister reads it. We do know that because we get phone calls and questions on the minister. But does anyone else? It's a very good question. Some people do, some people don't. So what's a more effective way to actually get this feedback to folk? We do what we call thematic review. So we look at certain areas and we feed back to the sector about our thoughts and findings. And I'll put this up because we take a restorative just and learning culture approach to this, which means it is primarily about learning. It is about where things have gone wrong. We want to make good for those who may have been harmed by the process, which includes not only patients and families, but staff as well too. So it is about a process an improvement process. It's a no blame process. So it's a specific area. So it might be on ECT, and I'll show you that in a minute. And we look at meaningful trended and aggregate data and analyze that. And then we disseminate that. Now, you might say, well, why are you telling us what to do? We historically just sent out the data and analysis and said, there it is. Services came back to us and said, well, what do you want us to do? Give us some ideas on what you think are sensible things to do. So we started to do that. And again, this is a little bit small, but this is a reasonably recent. It's distributed in April. It's our thematic review information sheet on ECT, and I'll go through that in a minute. We didn't just send that to the chief executives because it doesn't tend to get to clinicians if you just send it to chief executives, even though they say they send it on. So we have purposely sent this to a range of specific clinical leads and individuals we believe will kind of disseminate this. Now, I don't know whether you've seen this. I hope you have. But and this is the learnings from 10 years, if you like. ECT can only be administered with informed consent. Now, again, it seems really simple, but that's where we see the problems arise. With approval for the tribunal for involuntary adults or kids or under the Criminal Law Mentally Impaired Act. Again, seems simple. It's in the Act. It's a really simple step, but it happens in the transition often. In an emergency, because I'm technically available 24/7 as a chief psychiatrist, but we have delegates who can act on my behalf to approve emergency ECT, so they have to know the criteria as well. So they're the messages, and these are the actions that we've suggested. Use of a standardised pre-ECT safety checklist, which is checked and signed by the ECT nurse prior to administration of every ECT treatment to ensure correct patient, correct identification. Again, simple stuff, but it's the core stuff. Confirmation of legal status and mental health forms if in place. You don't just say to the person, are you under the Act or not? You go and check. Confirmation of approval by the tribunal. You check to see that the tribunal has sent through their confirmation. And looking at having a look at the written consent. And an audit from time to time of those checklists. It's the usual safety and quality cycle. The other one is the post-anaesthetic pre-ECT delivery time out. And what we've noted that I don't know if anyone spotted it, there's actually a mistake in our standards at the moment. We've said pre-anaesthetic rather than post-anaesthetic. So we're going to change that. But the post-anaesthetic pre-ECT, the anaesthetic is given before the ECT is delivered. There is a very clear statement that the anaesthetic has been given and that the ECT can now be delivered. And the reason for that will become clear in a minute. So that's what we send out. We try and keep it fairly simple. We don't personalise it to a service because some of these very serious events that might have occurred, which might, we don't. It's not fair for us to name and shame. That's not the aim of the game here. And that's nice. Name, shame, aim, game. I didn't realise it. That's very good. It's important that this is very general. So, but we are very clear that this is based on actual cases and it's the fair dinkum feedback from what's been going on. Okay, so if anyone needs to talk about the reporting, you can contact our monitoring desk as well. Again, colleagues in the Eastern States, I'm sorry, you can contact our desk. We'll respond, but we won't be any good to you. So it's only for WA. So what are the learnings? Now let's get to the nitty gritty. And Brian said to me, I was really pleased to see these learnings at the end. So that's good. So the learnings here, which I think are really generalisable across Australia, really. The key learnings for us are have a dedicated ECT director, psychiatrist, and ECT nursing coordinator. Why? When services have skimped on this and, for example, had an ECT coordinator that was running a ward at the same time as doing the ECT, that's when we've seen an increase in serious notifiable incidents. So it's a serious matter. ECT is not an add-on, it's a serious matter. You've got to have dedicated folk. Now, I'm not necessarily talking, some services might be small, you might not have a full-time person, but you still need dedication at the time of the ECT and in preparation. Again, we've talked about this over and over during this presentation. Check consent, check Mental Health Act status before every single ECT. It's really, really important. And unmodified ECT, this is what we're getting to, and for those who may not know, unmodified ECT is ECT without anaesthetic. Used to be done, went out in Brian will tell me, the 70s or 80s, I can't remember when the last unmodified ECT happened. Clearly now, it's not only not best practice, it's high risk, and it would be seen as clearly unprofessional behaviour. So No one goes out to do unmodified ECT these days, but if the anaesthetic is not given and you give the shock, that's unmodified ECT. Have we had cases in WA? Yes, we have. And when did the cases occur? The components to those were a very junior medical officer. This one's some years ago. Very junior medical officer who wasn't supervised, who wasn't credentialed, and who gave a shock before the anaesthetic was given. I've got to be careful because I think it's probably reasonable to discuss it. I don't think there will be any confidentiality issues here. The other one was where the service had drifted from the rigour of the post-anaesthetic timeout. They said, oh, well, we don't really need to do that. It's not that helpful. And they kind of changed the wording and it wasn't as rigorous. And ECT was given because the operator believed that the anaesthetic had been given, but the anaesthetic had not yet been given. So again, it wasn't malice on the part of the individual. It wasn't an intent. It was poor process. So they're the times when this has happened. Has it happened at other times that are not reported? Possibly. So if we take those two and maybe say there might have been one more in the last 10 years or so, we're probably talking about one in every 30,000 ECTs, treatments. So something like that. Not common, pretty rare, but it should be a never event, as you can imagine. How do you explain to someone? And that's where the vertebral column damage and the muscle tears come into play. When you have unmodified ECT, that's the risk there, of course. So we're talking rare events here. So we're not talking common events, but safety and quality is often about reducing some of the rarer events as well. Okay. The other learning is clarity around the roles between prescriber and operator for ECT. Does your prescriber know exactly what they're prescribing? Do they understand ECT enough to prescribe? Is there a check and balance process around making sure of that? Who changes the parameters? You might juggle the parameters a little bit, but who changes from unilateral to bitemporal, bilateral, whatever you're doing, either citing like that, either placement or major changes in formatting. So if that occurs, that really needs to be a conscious discussion between prescriber and operator. That's what we found gets blurred in services over time. It becomes the prescriber, services worry less about the prescriber and only think about the operator. That's the drift that we see in services. So it's really important in your policies, in your practice, have clarity and make sure your prescribers are very much part of the process and understand the process. And the other one is tracking of side effects. And the reason I say this is that everyone tracks side effects, of course they do, but there's quite a variability in how frequently and how this is done. And I think what I'm describing here is that there is significant variability in that across the sector. So it's, and variability is not necessarily a good thing. And side effects are the thing that tend to raise concern from consumers, of course. So it's really important to think about how you're tracking side effects and to see that as an important component. Again, I'm probably not telling you anything you don't know, but this is the learnings that we've got. Just a few contact points, and that's it from me. Very happy to open up to questions from, and apologies, I don't have the chat here, Brian, down the side, so I don't know whether anyone's put anything in the chat there. Would it be in the notes, or is that there? So let's get rid of the these. It's not touchscreen, is it? There we are, got rid of it. So
any questions from the room?
Can I just ask what folk think about why we're seeing a decrease in ECT over the last couple of years? Any thoughts?
Yeah, and that's our trend, exactly. We're tracking that for the past years. Some lovely linear increase of post-COVID that's seen that dip. Our ECT numbers have always been a predictable fraction of inpatient admissions. So certainly, I think hospital admissions in the private sector are generally down, and that's one reason. Finances, there are other issues for patients. Lots of people walking away from their private health cover.
Okay.
There's a lot of patients in my outpatient clinic when I see we get the usual 6 weeks. I say, can you make it 12? I'm hearing that a lot in the last 12 months. Really cost of living issues as well. I mean, impact on accessibility to private sector, which might explain some of that. Doing in Western Australia, private.
Yes. Oh, just for the folk online, I'll mention what you've, I don't know if people can hear you, Brian. They should be able to. Great. Okay. Great. So it's cost of living, reduced hospital admissions, although it's remained a reliable percentage of those hospital admissions, but the total hospital admissions have decreased. Yep. Yep. Any other thoughts of why we might be seeing less?
Maintenance is increasing. How does that relate then to total numbers of ECTs over a year?
That's a good question. I don't quite know. And again, I was interested in your thought about why we're seeing an increase in maintenance, even though we're seeing a decrease in total ECT. Is that because the reduction? But we also saw that the acute was relatively steady as well. Although it's dipping a little bit. I don't quite know why that is. Again, any thoughts on why the maintenance numbers are increasing?
Following biometrics, one of the natural parts of the evolution of an ECT service over time, patient private or outpatient, not that patient could be Hollywood has been something for the outpatient.
Yes.
Supposed to be inpatient.
So maintenance, I guess, is less than the usual 3 times a week, but
whether that's captured.
Yeah. Okay, so it might be a reporting issue in some ways. Yep. Okay.
With the decline in numbers, another factor may, and I suppose it's a similar sort of factor, but I think there's evidence that as psychiatrists are coming through and in the private sector, they're opting not so much for inpatient work, not so much for depression, mood disorder work, but being drawn to a more, the ADHD clinics, things like that. And it's very difficult for people to find access to a private psychiatrist who wants to treat difficult depression or even depression. I mean, so a lot of the psychiatrists working here who do work in that area, their books full or have been full for some time. They're not taking on the acute cases. So, and it did seem that it was the private numbers that were dropping back. In fact, the public numbers seem to be increasing, if I remember the chart.
Yeah, I have to go back to that.
I don't know whether that relates to some of the new public units opening up, but
we'll go back to those numbers. Well, we do have an increase in public numbers. There we are. So public and private percentages. Yeah, it is.
it's not decreasing.
It's not decreasing. Yeah, it's kind of hanging there. But so we've just seen Geraldton approved as a unit, but it hasn't opened yet. Prior to that, we had Bethesda open as a unit, but approved, but didn't proceed. But again, that was private. So at that time, so we haven't seen an opening of new public ECT units much, even though the public beds have increased reasonably significantly. Yep. And I guess another question I've got is, what do folk think about those kind of learnings, very kind of simple things that we get back to, check consent, check identification, etc. Again, in some ways, safety and quality often is can be a very simple thing in many ways. But why do you think we still get those reports around that? Why do you think that happens? Any thoughts? My thought is that human nature is what it is, and in the literature there's a phenomenon called default to deviance. So if we're left to our own devices over time, we may just start to drift off course because we don't have anything to calibrate with. And again, that's not about someone being malicious or intentionally not doing the right thing, but it's a natural process of drift, hence that kind of recalibration. That's why yearly credentialing, updating, doing the professional development around, for example, ECT for all staff, nursing staff, medical staff, all staff involved, is really important. Now, again, I know you know this, but I tend to think that's a component to that. And it is that, as we've seen, it is that kind of slip from, well, we don't have to do this because we're so experienced, we know this. And for example, the change to that post anaesthetic check is a classic example. We know, the work by Atul Wande, etc., around surgical checklists. Surgeons initially didn't want to buy into that because they were very, very upset that they felt their credentialing was being questioned, their skills were being questioned. But in the end, it's just a natural process that we're trying to prevent, I think. So those checklists, we don't want too many checklists. We don't want too much administrative burden. But at the same time, there are some checklists that are highly effective to reduce those never events, I guess.
Consent form issue, I think that in ECT there can be a bit of a mismatch between what's going on paper and what's going on in reality, so that the consent form may be valid, but the patient may no longer be giving consent. So it can look like they're giving consent because they're consented for 12 treatments and the form's in date, but they may have withdrawn their consent. So that verbal confirmation every single time is so important. And then the other time, or the other risk or scenario is where, they're very much giving consent. The consent's checked verbally. There may be paperwork, the date might be out by a day, or something like that, which so they're actually on paper, they haven't given consent.
No.
That is not a good situation, but in reality, they actually may give them consent, if that makes sense. So, so that's one scenario there. And then just coming to the issue of the pre and post anaesthetic timeout. So we've always done the post anaesthetic timeout, but with the guide to do a pre anaesthetic timeout, we've started to do that as well. And now I think that's been working well. So we've got the two now. So I wonder, but the pre-anaesthetic timeout that we're doing, there's reference to the medication that's been given. We were a bit unsure as to how to interpret that. So we're kind of referencing the most recent treatment and going through the treatments that were given at that treatment. And that, I think, has been helpful to verbalise that with the team present. And I'm just wondering when it changes to a post-anaesthetic timeout, will the details of the timeout stay the same, or
they're clearly two different functions. The pre is important as well, and the post is important for different reasons. So pre is important around identification, consent, medications, etc. The post is important to prevent unmodified ECT. So they're very different functions, and the standards we try and keep them as small as possible, so that they're not too onerous, and then the guidelines provide a kind of a bigger. So I guess so. I'd flagged that it was in the standards, the post, but actually doing this presentation, I'd actually double check that, and it was the pre. So we'll have to work that out, I think. But they're very different processes and trying to do very different things, I think. Yeah.
One other question.
Yeah, go ahead.
In relation to the and maybe some communication already between Ramsay to clarify this. So but I just take the opportunity to ask. There's a requirement to get a renewed consent with a change in the pulse. I think it refers to pulse. It says electrode placement, which we've always done. And the other one I think is wave length or wave pulse width, though I think in the guideline, but we're interpreting that as pulse width. And so we're kind of trying to work out how to implement that in practice, because I'm unsure whether that means changing from, for example, the pulse width program, so the 0.5 program, after breath program, or whether it's because as the dose increases, the pulse width can increase. Towards the high doses, the pulse width has to increase to get that energy, and that can happen in session if you have a mistreatment. 70% on the thimetron or whatever, and you're increasing you're in effect increasing the pulse width, and to get renewed consent in that would mean that you'd end the session at that point. And it may not be clear to people that they're actually, as they dial up the thimetron, they're actually changing the pulse width. So that was just a query I had, not necessarily for today, but.
And it's a really good point, because clearly electrode placement's pretty clear if you're going to change that, sure. And but where is the line between what is a significant change and a non-significant change? And in some ways, we don't have the legal precedent on that at the moment. So I guess some of that is going to be open for discussion to get clarity on that, I think. And as that's the thing, I guess, when we don't have legal precedent, it's very difficult to know, because some of this consenting is about it's for legal purposes as well as clinical purposes as well. So I agree that's quite a grey area, and we'll have to have that kind of further negotiation discussion. Any other questions or queries? Yes. That's right. It stays within the service. We only receive the tick box to say we've had this or not had this. We don't get details. So which is interesting. And I think we've talked about whether we pursue that. It's not a statutory requirement to pursue that information. And to some extent, we've just tried to keep an eye on general trends of that, because it is that balance between how much reporting about negative or side effects and negative events is helpful for the person and the development of services and the understanding of safety and quality. That's the challenge, versus the time it takes for a service then to write out all of the extra stuff that they require. It's always a juggle between practicality and value, I think. But yeah, very happy to hear any thoughts you might have on that.
How you would encourage a service to do those sort of things.
Well, certainly, we're very happy for services who might be interested to do their own internal audits on those processes. They can contact us at any time, and we can in fact, they've got their own information on that already, but we can provide, relative information about the whole of the sector versus that services information so people can compare. I think the issue is with things that happen very occasionally, it's difficult. You need almost a year's data or more to do that. Obviously, things like persistent headache or memory deficits, significant memory deficits are more frequent, and services can probably do audits over 6 months, 3 to 6 months to look internally, and we can certainly provide data, comparative data for people who are interested in that. So very happy if there are particular local audits that you want to do as part of your own safety and quality process. We're very happy to try and assist that with any data that you might not have as well, if we can.
The membership this year to be even more detailed with us. We'll be reporting out the ECT and more detail for the regular staff come on. No ECT data, that's some real good data on cognitive adverse cognitive effects and scrutinising all the reportable quite some detail. So we should have some really good data starting from, I guess, our 2024 data.
That's the thing. There's a gold mine of data. It's how do we use that? And the issue for us has been we've only recently had an increase in staff to be able to start to do an increased analytical process and feedback process, which is really important because that's what services want. Services don't want to send the data into this black hole of the chief psychiatrist's office and not receive anything. And so we've been quite gratified to be able to start to kind of feedback more data. Because that's the value. I think more analysis of data, that's the value as well. Yeah. And you come to us and say, can you provide us this benchmark? We'll either say yes or no, or we might say we can do it in X amount of time, but we're very open to those approaches because we would like to be more flexible. We now have staffing to be more flexible to do that. Previously we didn't, now we do. So we have a lot of staff going to say we're not flush with stuff. If any of the politicians listening, we're not flush with staff, but certainly we're very happy for clinical services to approach us and say we're interested to look at this. How can we use that data? Yeah.
Trainings in the ECT. So we have a strong tradition of getting our trainees in for 6 to 12 weeks, really getting immersed, very good close supervision. It's a really good learning environment. Now, the recent publications have referenced, obviously, you can't be unsupervised, which doesn't apply to us. And then it does get touch on might be appropriate or not appropriate to have signed off with a statement in there saying, look, this gets signed off to. That we get a lot of year one training who are, in my view, sure, they've all done ECT in public sector jobs with service registrars. But are you comfortable if we feel the passion that the training is mature enough to get that signed off in their field?
Yeah, certainly the college and the chief psychiatrist are two separate entities, of course, and so we're very happy for first year trainees who have been well supported to be part of that process. I mean, gone are the days. I relate my very brief experience of my first ECT as a junior doctor. I was a second year. In fact, I was a first year. I was an intern, and the hospital. I won't say which hospital. It was the Mater Hospital in Brisbane. At that time, they didn't have a psychiatry service, but they had a consultation liaison psychiatrist who could do ECT in theatre, and he was going on holidays. He very rarely had patients in the general hospital, but he had a particular patient who was going on holidays. So he went and said, come to ECT. He showed me an ECT. I did an ECT in his presence. And then the following week I was doing his ECT. Gone are those days, of course. And I'm sure that doesn't happen here. But certainly from our perspective, it's about, yes, the college has its guidelines, and we use that 10 sessions as a reasonable credentialing process. But someone can be a first-year registrar, a non-training registrar who's been trained, been experienced, and can do that supervised ECT appropriately. The cases I described where with the unmodified ECT, that person had probably not been properly trained nor probably not supervised properly at that particular. So it's a different issue, I think. So absolutely, from our perspective, I think it's about the nature of the local credentialing that's important. So